Não estou ouvindo. Boa noite a todos ligados na Flá TV, boa noite a todos aqui no auditório Rogério Steinberg. Dentro de instantes daremos início à palestra com o tema Como Gênero e Sexo Influenciam nas lesões de ligamento cruzado anterior. Participarão da palestra o nosso doutor Cláudio Cardone, coordenador médico do Cuidar, a Camila Carballo, que é pesquisadora e PhD do Hospital for Special Surgery em Nova York, o HSS, e também a Ellen Casey, que é médica da Ginástica Artística da Seleção dos Estados Unidos. Então, vou passar agora a palavra ao Dr. Cardone.
Boa tarde, obrigado a todos pela presença. Thanks, Dr. Ellen, for being here. For us, it's a great honor to have you here tonight. I'm sorry for the late, and now we can start your speech, please. Dr. Camila, thanks also for being here.
Wait. Oh, there we go. Coming back.
A gente perdeu o sinal um pouquinho. Na verdade, acho que agora a gente só está com a Dr. Ellen, né? A gente pode dar início quando...
Vocês conseguem ouvir a gente?
Sim, conseguimos.
Ah, beleza, porque perdemos vocês, mas acho que agora voltamos.
Agora voltamos, então tudo certo. Tecnologia tem dessas coisas, né? Acho que agora a gente pode dar início. Vou pedir só para você começar novamente, porque a gente acabou perdendo o sinal, né, logo no início. Então, por favor,
sem
pode
problemas,
dar
sem
início
problemas.
aí, doutora Camila. Muito obrigada.
Então, eu vou fazer... Dr. Case, I was just going to do a brief introduction in Portuguese and I'll give it to you.
Okay.
Boa tarde a todos. Na verdade, eu gostaria de inicialmente agradecer ao Dr. Cláudio Cardone e ao Flamengo pelo convite. É um grande prazer estar aqui moderando essa palestra. E uma grande honra também poder trabalhar com a doutora Casey nesses últimos anos. A gente tem feito alguns projetos em colaboração. Eu vou dar só uma breve introdução sobre quem é ela. Então, ela fez faculdade de medicina na Universidade de Virgínia, completou a residência em medicina em reabilitação, fez um fellowship em medicina esportiva em Chicago, e ela atualmente é médica fisiatra no Hospital for Special Surgery e professora em reabilitação clínica na Weill Cornell Medical College. Ela tem uma especialização muito mais focada em atletas femininos e, como ex-ginasta, é apaixonada por cuidar não só de todos os atletas, mas principalmente de ginastas e dançarinos, sendo médica da Seleção Feminina de Ginástica dos Estados Unidos desde 2019. E ela também é pesquisadora e atua ativamente em pesquisa na área de medicina esportiva. Já recebeu inúmeros investimentos para apoiar sua pesquisa, bem como vários prêmios, incluindo o de Top Doctors em Nova York em 2020. Então, agora eu vou passar a palavra para a doutora Casey para ela poder começar a apresentação. Dr. Casey, I'll let you take it from here.
Thank
It's a pleasure to have you.
Thank you so much. I hope you all can hear me, and I'm going to share my slides with you. Let's see. Move that. Okay. Camila, can you let me know if you can see these?
I can see this, yes.
Okay, great. All right. So it is such an honor to join you all virtually. Thank you so much for having me. And hopefully we can all meet in person someday. But for the next little bit, I'm going to focus on a topic that I'm very interested in, both from a clinical and a research perspective. And that's how biologic sex and gender influence the risk of anterior cruciate ligament injury, and what this means for gymnasts, and so many of us have caring for gymnasts in common. So a little bit of background is that, as you heard, I'm a physician and a researcher at the Hospital for Special Surgery, where I've had the privilege of working with Camila as well as Dr. Scott Rodeo. And I'll talk a little bit about our research. And then I've also served as the team physician for USA Women's Gymnastics National Team since 2019. And so these are just a few pictures from either the Olympics or World Championships. And you can see the black and white picture where I'm hiding in the back of the warm-up gym trying to write a research paper while, being away and taking care of the gymnasts. So sometimes we have to do two things at the same time. So what we're going to focus on today is, as many of you know, there's multiple factors that lead to the risk of an ACL injury. I wish it was as simple as just fixing one thing and we could avoid the injury, but we know that there's many pieces to the puzzle. And so we'll talk about the anatomical factors as well as what hormones do to risk of injury and neuromuscular control. And then, because we have some common interest in gymnasts, we'll talk specifically about ACL injury in gymnastics. So this slide we almost always show in the United States when we talk about the differences between male and female athletes in sports medicine, because for us, 1972 was a very important year where basically there was a governmental law that said that girls and women had to have the same opportunity in sports as boys and men. And so after 1972, there was a significant rise in the numbers of girls and women participating in sports. You can see on this graph, this just looks at high school athletes, but this dramatic rise in female athletes from 1972, this stops at 2011, but of course it goes on till present day. And one of the things that occurred after, sports medicine doctors began to have more girls and women, seeing them for sports injuries, is they began to see some different patterns of injuries between boys and girls. So this is just a cartoon graphic of soccer injuries in high school athletes. And what the numbers show is, high school boy soccer players are more likely than girls to hurt their shoulder, hand and wrist, and lower leg, whereas girl soccer players are more likely to get head and face injuries, and this includes concussion, knee injuries, including ACL injuries, and as well as injuries to the ankle. So we often think about, at least in the United States, when we say, female athletes are at greater risk for some injuries, and we forget about the fact that male athletes are increased risk for other injuries. And so, in our lab, we want to understand why that occurs. And I guess the good news for us, since we're lifelong researchers, is there's a lot of questions behind why this happens. And I'll kind of talk through some of those in terms of ACL injury. For the purposes of this talk, I'm using the term sex to basically classify a person based on biology and physiology to be male or female. And then gender, the classic definition is, how a person identifies as male, female, or non-binary based on their self-perception or socially constructed roles. So for the most part, we're talking about sex in terms of the research that we do in Dr. Rodio's lab. So when we think about factors that fall under that umbrella of sex characteristics, we might think about the joint morphology or the shape of the joint, tissue material properties, meaning how strong or how resistant to force the ligament itself might be, sex hormones and how those fluctuate, certainly in women across the menstrual cycle, which is not something that males experience, and then neuromuscular control, or the patterns in which people move when they do sport-specific things like jump, land, for example. The factors that fall more under the gender umbrella include things where girls and boys might have different exposure or experience. So they may have different training exposure. In some instances, they might have different access to equipment or different types of coaching. In some sports, there's different techniques. And in gymnastics, for example, obviously there's 6 events for male gymnasts and only 4 for females. And the female events are more leg dominant, and the male events have a few more upper body dominant, events. And so the demand on the athlete is different. And so all of those factors come into play when we think about sex and gender. Now, neuromuscular control may actually fall more under gender because movement patterns, as we know, can be trained. And it's possible that based on environmental features like exposure to, let's say, proprioceptive training or injury reduction programs like the FIFA 11 Plus, for example, boys may be exposed to that earlier than girls or vice versa. So gender may affect movement patterns as much as sex does. And I think we all know this in sports medicine, that ACL injuries are a prime example of sex and gender differences in sports medicine. We certainly know this from the recent Women's World Cup for we say soccer, of course, we know it's really football, where there were such a significant amount of athletes out with ACL injuries. In our country, we see this significantly in basketball, for example, and lacrosse players as well. So I'm going to use these little soccer players as an example just to highlight kind of the differences as kids age and how risk of injury changes. So these 2 kids here are, let's say they're, brother and sister, they're fraternal twins, right? So they're both 8 years old, and they both started playing soccer at age 4, and they've played on the same teams because in the United States, usually the younger teams. So they've had the same practice time, the same gameplay. And if we watch them play, their patterns of running, kicking, jumping, landing, cutting are going to look pretty similar. And fortunately, in this young group, the rate of ACL injury is low, but it's pretty equal for Sarah and Mark. Now, if we fast forward about 10 years, and let's say, they play for a college team in the United States, they have similar practice time and gameplay, but if we watch them play, we might see some differences in how they move, especially in changing direction quickly, like cutting or maybe landing. Now, not every girl is going to land a certain way, or every boy is going to land a certain way, but if we look at large numbers of people, we're going to see some differences based on sex and gender. And the unfortunate thing, as you all know in sports medicine, is that Sarah is 2 to 8 times more likely to sustain an ACL injury than her brother Mark. And so that's really where I became interested in researching this topic. The reason we have a range of 2 to 8 is because if you look at a variety of studies that look at different sports, so here you see soccer, basketball, and handball, and different levels or ages. So we look at youth as well as high school, college, and you can see the range, is really anywhere from that 2 to 8 times. But regardless of the study, we've seen time and time again that our female athletes are at greater risk of especially non-contact ACL injury, meaning that they didn't crash into an opponent or equipment. It's that sort of landing, changing directions, movement where the risk is highest in the female athlete. And it's not just the risk of one-time injury that's higher in female athletes. It's also males are more likely to return to sport 12 months after an ACL injury and surgery. So this is data that shows that about a little more than 75% of male athletes return to their prior level of sport, whereas only just above 65% of female athletes return. And certainly there's a lot of reasons for that, but it is disappointing to see that less females are able to return than males. The sex and gender gap persists even further in that females are at greater risk of tearing their other ACL, so the opposite knee. And then some studies show that female athletes are more likely to tear their graft or the reconstructed ACL, although other studies show that the risk of that is similar between males and females. So like I said, when we think of risk of injury and all the factors that come into play, we have to think of it like pieces in a puzzle. And so I'm going to talk about the different pieces and how that, is different between males and females. So one of the things we consider are anatomical risk factors for ACL injury. Of that femoral notch may be more likely to tear their ACL. And the idea is perhaps the ligament itself is sort of stretched or strangulated against the bony morphology. Those who are at greater risk to tear their ACL have a smaller ligament when compared on MRI. And then more recently, people have looked into the slope of the lateral tibial plateau. So people with an increased posterior inferior slope have a greater risk of ACL injury. And then also those with increased laxity. So kind of the looseness of their tissues, usually based on their collagen or connective tissue. And we can test this with a device that you can see up here, like the KT2000, which just basically pulls on the tibia. It's kind of an instrumented Lockman's maneuver. And then finally, athletes, especially in the high school population with increased BMI, have been shown to have an increased risk of ACL injury. So these can occur, of course, in male or female athletes. But if you look at athletes on a whole, females are more likely to have all of these factors than males. So notch width, the smaller ligament, the increased slope, increased laxity, as well as BMI. Another area that has been probably most heavily researched in terms of ACL injury is motor or neuromuscular control. And so what we have seen in countless studies, of course, is differences in landing mechanics. And like I said before, not every female lands one way and every male lands another way. But if you look at the picture in the top left corner, you can see what's called that box jump, where the athlete jumps off a box and then lands and sometimes jumps again. But in this first picture here on the upper left, you see the first person landing with that dynamic valgus. So the knees are coming together in the coronal plane. And then the second person is landing with their knees more in the neutral position, and also with more hip and knee flexion. And if you look at group data, the girls are more likely to land with that dynamic valgus than boys. So again, that's in the frontal plane. If you look to the picture that's over on the right-hand side, you see the sagittal plane, where this girl is jumping off the box, landing, and then rebounding or jumping again. And then actually in this picture, she's showing some very good mechanics with adequate hip and knee flexion. She's not, overutilizing her quads versus her hamstrings. But in this picture here, where you can see this athlete is landing with less hip flexion and less knee flexion, and this is a riskier landing pattern when you think about, risk of ACL injury in sport. The good news about these landing patterns and the risk factors are that we do have great data in the sports medicine literature to show that teaching athletes to move with better strategies can reduce the risk of injury. But I don't know if you've had this problem in Brazil, but in the United States, even though the data looks really good in these programs per risk of injury, it's hard to get coaches and athletes and parents to do them because a lot of people don't want to think about injury. They want to think about performance. And so even though they've been shown to be effective, it's hard to get buy-in, especially for people to do these programs every year over the course of time. And there are still questions about, are these programs as effective in both males and females, and what the exact kind of timing of these programs, at what age should they start, how long do you need to do them? And so more research needs to be done there, but certainly these programs are probably the most promising things we have to reduce risk of injury. The last two sections of our puzzle I'm going to talk about together, and those include sex hormones and then the tissue material properties, so the ligament specifically. And so, you may ask, well, why on earth would you study hormones in this area? And what I would say is, like we looked at Sarah and Mark, those little kids playing soccer, they've got similar hormones, they have similar motor control patterns when they play, and they have similar risk of injury. But we know that at the time of puberty and then beyond, male and female athletes clearly have a different exposure to sex hormones. They start to develop different motor control patterns often, and the risk of injury diverges and it becomes significantly greater in a female athlete. Additional reasons to study this are that one of the hallmarks of puberty, of course, is that female athletes are subjected to cyclic changes in both estrogen and progesterone, as well as other hormones across the menstrual cycle. And this is just a cartoon graphic menstrual cycle where you can see in the early cycle, in the follicular phase, estrogen and progesterone are low. Right around the time of ovulation, estrogen peaks and then drops down again. And then in the later luteal phase, you have another peak of estrogen and then the progesterone peaks. And so what research has shown us is the risk of ACL injury seems to be highest around that late follicular phase when estrogen is rising and progesterone has stayed low. In addition, if you look at the laxity as measured by the KT2000, for example, in the knee, the laxity increases at that same time around the peak of estrogen. And then there seems to be another increase in laxity towards the well, we know that there are sex hormone receptors on a lot of tissues, including the ACL, but also tendon, muscle, and nerve. And not only estrogen, but progesterone, testosterone, and relaxin have receptors on these tissues as well. And this is one of the things we're starting to study in our lab with some of the mouse work, but the thought is that the estrogen or these hormones are affecting maybe the cross-link of the collagen fibers in a ligament or tendon, for example. And so, we're not thinking necessarily that new collagen is being, built up and broken down over the menstrual cycle, but it's possible that the acute changes in the sex hormones are changing the cross-linking between the fibrils, as you can see in this picture here. So estrogen and relaxin are believed to decrease the cross-linking and therefore maybe make the ligament more vulnerable to stress or weaker. And the progesterone and testosterone have the opposite effect. So they may increase the cross-linking and make that ligament stronger. And you can imagine if these hormones are fluctuating over a quick time in the menstrual cycle, then, you may really have shifting stability of a ligament, for example, if this really, is true as we research it further. The other thing that's really interesting is that around the time in the menstrual cycle when injury seems to be highest, laxity is highest, there also have been studies looking at movement patterns or neuromuscular control, and that seems to change around that same time period. And so my, big hypothesis in the type of research that I do is to look at what is the effect of these hormones on the ligament itself, the movement patterns that the ligament is then exposed to, and then how does that influence the risk of injury? And I'll share with you one study that highlights this connection. So this is work that basically took athletes and tested them at different times across their menstrual cycle, and they put them in a motion lab, as you can see here. They have a bunch of sensors on them, and they're the motion capture cameras, and they have the athletes do both a cutting maneuver where they run and change directions, and then also jump and land, so they're decelerating. They also checked their ligament laxity, and they found that around the time that these athletes were ovulating, when their estrogen should have been highest, they had the most amount of knee laxity. And the people that had a big change in their knee laxity in the study, they also showed increased knee valgus during a cutting maneuver. So that dynamic kind of valgus collapse in the frontal plane, that increased as well. And so all of these things kind of happening at the same time might be the perfect storm in some athletes where their risk of injury is increasing. Now, you might say, well, why on earth would you bother to study this? Because what can you possibly do about the hormones? I mean, we want our athletes to be having healthy menstrual cycles, so we want the hormones to be fluctuating. But there are quite a number of athletes who are taking hormonal contraceptives, and that might be in the pill form, the patch form, an intrauterine device, and those hormones affect the natural hormones. And there are actually 3 studies, which I've highlighted here, very large databases, which have shown that oral contraceptives, so the pills that people take to prevent pregnancy, but they're used for a lot of other things, may actually reduce the risk of ACL injury. And so, the most recent one was from 2019, that you see in the bottom row here. And that looked at basically a huge database of Pearl Diver as a registry, usually using emergency room data. And when they looked at all that data, it showed that basically in high school age women, those who were exposed to oral contraceptives had a reduced risk of ACL injury, and the number needed to treat was only 6 for that. And I'm not proposing putting everyone on oral contraceptives, but if our athletes are choosing to use a hormonal contraceptive anyway, what we're trying to explore is there a way to choose one that would be safer or help reduce the risk of ACL injury more than another? And as you know, the reason this might work is that by taking oral contraceptives, the body is ingesting exogenous or externally made ethinyl estradiol, as well as a progestin. And the thought is that by taking that medication, you're blocking the hypothalamic pituitary ovarian axis, so the athlete would then be making less and having less fluctuations of the endogenous estrogen and progesterone. And so the exposure to those, those hormones that they're taking in the pill would blunt the fluctuations in the cycle. But what's important to figure out how those hormones that are in the pills affect the ligament as well. In order to sort out if this was worthy line of investigation, this is data from a study we did looking at 1,000 college athletes, female athletes in the United States, and we asked them, how many of you use hormonal contraceptives? And over 60% were using them. And then of the group using them, as you can see here, over 60% were using oral contraceptives in the pill form. And then the next most common was an intrauterine device, and then the ring, and then the implant and an injection. And so we did this because we wanted to see how relevant it is to study, you know, how oral contraceptives affect the ACL. And that still appears to be the most common source of hormonal contraceptive used in college athletes, at least in the United States. And so what we're starting to do in a mouse model with the guidance of Camila and Dr. Rodeo is to look at what types of birth control would be most beneficial or reduce the risk of ACL injury. And we break these down by the amount of estrogen in the pill. So low estrogen pills are going to have less than 20 micrograms in them, for example. And then the progesterone can either be a more estrogen-like with low androgenicity and low potency, or it can be more like testosterone with high androgenicity and high potency. And so before we got to that, we decided to just create a mouse model where we looked at male mice and female mice. And we showed that, like in humans, when you rupture the ACL in the mouse, it takes more force to rupture the male mouse ACL than it does the female. And now what we're working on is basically giving the oral contraceptives to the mice in their food. And we're going to compare mice with different types of those oral contraceptives to try to get a better answer to the question of, could oral contraceptives help reduce the risk of ACL injury? And if so, which ones are the most helpful? So all that to say that, you know, really our passion is to sort out, you know, which risk factors we can modify and reduce the risk of ACL injury in all of our athletes, and not just, you know, female athletes, because if we can understand how both sex and gender and hormones and anatomy influence risk, then ideally we could lead to a more personalized injury prevention or reduction strategies for both male and female athletes. I'm going to switch gears a little bit because, you know, with our, you guys have such a robust, you know, gymnastics program there. And I have, you know, the privilege of working with gymnasts in our country. So I want to share a few things about ACL injuries in gymnasts. As you know, this is a common injury in our gymnasts. But actually, I wasn't sure if there was a difference in male and female rates of injury, you know, prior to really putting this talk together. So there were studies that I looked at. One was a Swedish study of competitive gymnasts, which found that 37% of knee injuries in gymnasts were of the cruciate ligaments. It didn't specify anterior or posterior. And they also showed that this is a big deal because 16% of these athletes had to medically retire based on this injury. And in their study, they found that females were, you know, had the same risk of injury as males. There was another systematic review of college athletes in the United States that showed the risk was greater in female athletes than male gymnasts. Particularly, they put gymnastics in the category of high impact rotational landing sport. And I think that's a nice way to think about it because, you know, in the ACL injury world, we think about contact and non-contact injuries. And typically non-contact, like I said before, is, you know, landing, changing directions, decelerating. But contact, of course, is more like in American football where you have, you know, or rugby where somebody is colliding into the athlete's knee. Gymnastics is really, we don't see a lot of the classic non-contact injury, but we are seeing, you know, contact with the equipment in landings in particular. So gymnasts are landing with such high velocity, often while still twisting or flipping. And that is when, you know, these ACL injuries are occurring for them for the most part. So there's been a lot of attention about landings or landing strategy in gymnastics. And unfortunately, as you all are well aware, the Federation of International Gymnastics and the Code of Points is part of what drives the landing strategy. So these are pictures I borrowed from a colleague, Dave. Kind of that same pattern that I showed before. for in the landing. And often we worry about our female athletes and gymnasts relying on the kind of passive structures like the ligaments and the, bony morphology rather than actively controlling that landing. And then, as I mentioned, the still twisting while landing is a big factor in gymnastics. Where a more optimal landing for a gymnast to reduce potentially risk of injury would be like that softer landing where they're absorbing more with the larger dynamic muscles. They're bending their hips more, they're bending their knees more, they have enough dorsiflexion of the ankle, and they're having their knees more kind of under their shoulders and not coming to the midline. It's exciting to know that the Federation of International Gymnastics is starting to listen to some of the concerns from the medical crew about, our concerns about the landing. And they are, I thought it was going to be a new rule. It's not necessarily a rule, but they're basically going to allow for the feet to be apart. They're not saying how many, exactly the distance apart, but not quite shoulder width, but they're letting them be apart and not directly together without incurring a deduction, which I think is a really exciting and actually, progressive move for them, because they're reluctant to change a lot of things. But if we can get the rule or the code of points to allow for a better biomechanical landing strategy, I think that will help quite a bit in the sport of gymnastics. So I want to make sure we have time to discuss and hear your thoughts. So I have an ending picture here from the Tokyo Games where you can see two of our wonderful American gymnasts doing a fun pose. And then this is my colleague, Dr. Marcy Faustin, who's my co-team physician, and I, showing them the doctors can do the same stuff as the gymnasts. So with that, I'm happy to take any questions, and I certainly want to just say how much I enjoy being at these competitions with Team Brazil. I love to watch the gymnastics and the teamwork, and so it's really, really nice to be here with you all.
Thank you, Ellen. So I would like to open for questions. Let me go for Portuguese now, and then I'll get back to you. Oi, gente. Espero que vocês tenham gostado. Gostaria de saber se alguém tem alguma pergunta para ela. Não consigo te ouvir, Cláudio.
Agora sim.
Agora sim.
Thank you so much, Dr. Casey, for your enlightening lecture. For us was an honor to have you here. Eu vou começar a pergunta, tem esse direito aqui, Camila. E a minha pergunta é uma dúvida. Não é uma dúvida, mas é um conceito de muito tempo, enfim. Doutora Ellen, agora com essa experiência, a gente já conversou um pouco sobre isso até antes aqui da palestra, mas a gente viu que as crianças são muito parecidas, principalmente em relação ao controle motor, e a gente sabe que a ginástica, o grande problema médico que eu vejo na ginástica é a precocidade, né, do esporte, com uma grande intensidade desde o início. E isso é cultural, é do mundo inteiro, enfim, todo mundo trabalha dessa forma. Eu queria ouvir um pouco a visão da doutora Casey sobre isso, se isso deverá permanecer para sempre, ou se há alguma visão aí no mundo da ginástica que sugira algum tipo de alteração, ou na precocidade, ou mesmo na intensidade do treinamento. Essa é a minha primeira pergunta, depois a gente vai abrir a todos, em relação também à palestra.
Tá bom. Dr. Casey, one of the things that we were discussing before is about how early the gymnasts, they start their training and how the volume and intensity of the training. So Dr. Cardone would like to, if you would like to talk a little bit more about, like, what do you think about, like, the fact that they start so early, the fact that they have a high level and, like, intense, like, training all the time. And I would say, like, my other question together with this one will be how early the gymnastics, like, athletes could start high intensity training following an ACL tear or an ACL reconstruction. What do you think about that?
Yeah, great question. So generally speaking, you're right. The gymnasts are, training so early and so many hours that it's, in the United States, a lot of other sports are becoming like that, but gymnastics and figure skating and dance have been like that for a long time. It is difficult because we're actually doing a study right now where we're surveying the coaches, the gymnasts, and the parents, because I'm not sure if the reason that that's the case is because people believe that that's what you have to do to be competitive, or they think that if you don't learn this skills before puberty, you're not going to learn them because you'll be too scared, or you won't be strong enough, or you won't be ready. Now that gymnasts in the women's group are older, right, both in our country, certainly Brazil, we've got Canada, we've got a lot of people where they're older than they were previously. Our hope is that it will show the gymnastics community that you don't have to be at your peak by age 14, 15, 16. In fact, if we can train smarter and not push people so hard earlier, they could have longer careers. And people, the gymnasts in Brazil, for example, are showing that. But our hope is if we can understand why they're doing it, then we can maybe do education about what makes sense and what doesn't make sense. We're never going to probably get gymnastics or people in gymnastics to do multiple sports until the age of 14, right? That's kind of what we tell, people they should do. Play 3 sports a year or more. Don't specialize until 13, 14. That's never going to happen in gymnastics. We have to accept that. And it may be that you really need more of the time focused, but we do need ways to monitor workload, do injury surveillance on a international level. And I know in Brazil, you've got some people working on workload tracking, which is very awesome and a passion of mine as well. And I think the more we can have actual scientific data to share with the coaches, share with the parents, share with the gymnasts, that you don't have to do it the way they've been doing it for 30 years just because you're trying to keep up. We can actually train smarter, perform better, get injured less, and have longer careers. I mean, that's my hope.
Yeah, I agree.
In terms of the ACL question, I mean, we all want everybody to be able to come back as fast as possible. But for the most part, we're not clearing people for return to full gymnastics for 9 to 12 months in the United States. Because, the risk of re-injury is high. And so, but if they're meeting all their benchmarks in physical therapy, certainly around that kind of, 9 months is really kind of reintroducing back to gymnastics, but maybe not as many of the twisting skills, more flipping to get the air sense back before, doing it in a harder competition setting.
Makes sense. Yeah. Thank you.
Mm-hmm.
Does anybody else have other questions? Alguém tem mais perguntas?
Camila, você poderia, assim, em linhas gerais, só traduzir essa resposta que foi extremamente interessante aí para nós?
Sim. Ellen, I will just translate a little bit, like, summarize a little bit what you said to them, like. Ela falou que realmente essa questão da precocidade é algo internacional, né? Que os níveis vêm de décadas, né? Principalmente na ginástica, que os níveis e o volume de treino tem sido muito intenso, mas que ela tem visto alguma pequena mudança né, com relação a esses últimos anos agora, mas muito baseado em evidência, né, na questão científica. E ela acredita que se nós pudermos fazer mais estudos que mostrem o quanto isso é importante no quesito de você não necessariamente precisa ter um atleta de 12, 14 anos fazendo um treino de alto volume, de alta intensidade para ser um atleta de ponta, e na verdade você ter treinamentos, né, do controle motor e outros quesitos envolvidos de uma forma mais inteligente, né, para esse atleta, a probabilidade dele alcançar um nível muito alto a longo prazo e ter uma vida musculoesquelética mais saudável, né, a longo prazo também influenciaria. Então, e a outra coisa que ela falou foi a questão do risco de lesão, né? Que aqui nos Estados Unidos, eles não liberam o atleta, né? Pelo menos na ginástica, antes de 9 ou 12 meses, mesmo que eles tenham batido todos os milestones, né? Todas as partes deles, por conta da questão do alto risco. Então, eles tentam fazer. Num resumo, foi isso. Vocês estão conseguindo me ouvir?
Alguém aqui no auditório tem uma pergunta para a doutora Casey? Gostaria de perguntar? A gente... Claro, só um minutinho. Passar o microfone aqui.
Camila, você está me ouvindo? Vou perguntar em português e você traduz para mim.
Eu acho que deu uma travadinha, mas daqui a pouquinho volta, né? A gente está com um pouquinho... oscilando um pouquinho ainda. Ok. Camila, você consegue nos ouvir?
Oi, agora sim, sim.
Ok, perfeito. Vou passar aqui para a primeira pergunta, tá bem?
Tá, Camila,
ótimo,
tudo
obrigada.
bem? Meu nome é Paula, eu sou médica do esporte. Vou perguntar para você, se puder traduzir para a doutora, por favor, tá? Porque essa questão de contraceptivo, né, de proteção para lesão, principalmente de cruzado, está sendo bem discutido, principalmente do futebol, né, que vocês comentaram, na Copa do Mundo teve bastante. Queria saber como vocês trabalham, como ela trabalha isso na seleção de ginástica, mesmo porque os dados ainda, o N eles são pequenos, né, nos trabalhos, e enfim, ainda não se sabe se realmente, acho que a conclusão final é que ainda que não se protege. Eu vi que tem alguns dados aí, mas o N é muito pequeno nos trabalhos, né? Obrigada.
Nada. Ellen, she was asking about more about the proprioception work and training, because the scientific work right now have a low number of I would say athletes or patients that can prove if the proprioception work is actually good or beneficial for the gymnast. So what are your thoughts about that?
And meaning injury reduction sort of, landing strategies, that sort of thing. Yeah. Mm-hmm. It has certainly not been studied in gymnasts. I think, well, it can't hurt, training the proprioception, though I think since gymnasts generally aren't getting that typical non-contact, deceleration, change position, cutting, that's not the mechanism. I think probably spending the time proprioceptive on the gymnastic landing position, working on that primarily rather than adopting all of the FIFA 11 plus, for example, for gymnasts or, there's so many programs, but it does probably need to be studied in detail and, studied in this population. And it's hard because although these injuries are common, they're not happening every day. So you need a large number to study. But I think really focusing on the landing position and, really pushing the FIG to make the changes that allow for as safe landings as possible probably are the way to go. I don't think doing those programs can hurt, but I'm not sure how effective they would be in our gymnasts.
Mm-hmm. Thank you.
Mm-hmm.
Paula, vocês conseguiram entender?
Traduzida, Camila, para... Eu acho até que a Paula
claro.
Conseguiu entender, mas de repente para o restante das pessoas presentes?
Não,
online?
sem problemas. Sem problemas. Ela falou que, no geral, realmente concordou com a Paula, que precisa-se de mais estudos, né, nessa área, porque, principalmente na questão da ginástica, mas ela acha que talvez fazer o trabalho de propriocepção seja importante, mas com foco, né, no caso da ginástica, na questão do landing, né, da descida, né, porque é onde você tem um maior risco de lesão. Né? Não é chegar lá e fazer, por exemplo, todos os trabalhos de propriocepção que a gente faz no jogador de futebol, mas sim uma coisa muito mais focada para o tipo de esporte, para o tipo de atleta, e que sim, não tem uma resposta, assim, cientificamente falando, concreta, né, para dizer se o trabalho de propriocepção é algo muito benéfico ou não para o atleta. Então, precisa, sim, de mais estudos para a gente poder afirmar se o trabalho de propriocepção é algo que tem que ser levado em consideração ou não, né?
Vou passar aqui a palavra para a nossa coordenadora técnica da ginástica, Georgette Vidoro, uma verdadeira lenda, vai fazer aqui. Essa pergunta vai ser boa.
O que eu gostaria de saber é sobre a Federação Internacional de Ginástica. Como ela se posiciona em relação aos médicos que trabalham diretamente com a ginástica artística e que vem apresentando, isso há anos, não é de agora, que as lesões acontecem, né? Então, como é que é a posição da federação? Porque é ela que cria as regras, né? Ela que faz toda a ginástica, a evolução da ginástica, é ela que permite que elementos de altíssima dificuldade sejam feitas, e é preciso treinar para isso, para se conquistarem os resultados. Qual é a posição da Federação Internacional, se ela tem algum diálogo com os médicos das seleções, ou se isso não é falado, não é discutido?
Georgette, obrigada, é um prazer também te ter nessa audiência, grande fã do seu trabalho também. Deixa eu só te perguntar uma coisa, com relação à federação, a pergunta é no geral, com relação ao médico e a federação, como é a comunicação entre eles, ou
se há alguma discussão, eu acho que em relação aos Estados Unidos, o primeiro país do mundo, eu acredito que eles tenham uma interlocução com a Federação Internacional de Ginástica, e se há essa interlocução, e qual é a posição da federação em relação a esse número tão grande de lesões que acontece na ginástica?
Obrigada. Ellen, the question is about more the International Federation. If you guys as a physicians, you have an open door to discuss with them about everything that happens. And if you have any feedback from them in terms of the amount of injuries that are so high on the sport, how do you discuss that? And if it's possible to discuss with them, and then how they see levels an increase of injury on the sports, if they take any measurements or anything.
Yeah. Now, do you mean, do I talk to the people at the Federation of International Gymnastics or at the United States level?
The international one, yeah.
Okay. So the communication is getting better. I think partly, the more you have been around, they kind of develop more of a relationship, and they they collect data at all of these events with a form, that you fill out. If I'm covering, then I have to write, this injury occurred. So they have a lot of data. They haven't ever shared it or published it, to my knowledge. I've offered, and others have offered to, help if they just wanted help to look at it and publish it. So they haven't shared as much data as would be helpful. But those are just the problem is that's just the big competitions, right? And so we actually need to do a far better job of what's happening, the young kids, all different ages across time. And we have worked with from a bunch of different countries. We're actually writing a consensus statement about how to, define the injury, report the injury. And so if we all do the same thing, then we can, pool our data together and do it, even if the federation isn't going to do it on their own, we can do it. And we would love to collaborate with anybody. And I think, one, you have to be able to count the injuries to show it's a problem. And then you have to keep doing it so that if you make a change, you can show that, it's improving. Gymnastics doesn't use a lot of scientific data like other sports. And so if we all work together, Brazil, United States, everybody's doing something, but if we can
Então, só para resumir o que ela falou, mesmo para eles, como médicos dos Estados Unidos, para conversar com a Federação Internacional não é tão simples, eles não têm essa abertura toda. Ela falou que está ficando um pouco melhor, né, com o passar dos anos, eles têm conseguido ter um pouquinho mais de acesso a eles e discutir determinados aspectos, né, principalmente na questão das lesões. O mais interessante que ela falou foi que toda competição ou grande competição, eles têm que preencher, ela acha que todos os médicos, acho que de todas as federações de cada país, né, tem que preencher formulários com dados dos atletas em relação à lesão. Fazer agora, e que ela acha importante também, é que mesmo você começar a coletar esses dados em competições menores, não só nas competições grandes, né, como Olimpíada, Pan-Americano, atletas, incluir os atletas mais novos também, que têm um risco de lesão alto, e, na verdade, ela está chamando as pessoas para colaborar, os países para colaborar, já que a Federação Internacional mesma não publica. E ela falou que ficaria feliz em poder colaborar com o Brasil também. Então, eles estão chamando os médicos, de uma forma geral, de cada país, para poder tentar coletar esses dados que eles têm e eles mesmos passarem a publicar para ter uma ideia melhor. Mais alguém?
Mais alguém tem uma pergunta para a doutora Casey? Tem?
Oi, tudo bem? A minha dúvida é qual a opinião da doutora em relação a aumentar a idade do feminino para 18 anos, assim como o masculino?
Para começar, que você diz?
Não, nas competições internacionais, o adulto masculino é a partir de 18 anos e o feminino de 16.
Sim. He's asking about like what's your opinion in terms of like the age limit, like what do you think about like starting at 18 males and female instead of like younger for the high level competitions?
It's a really good question, and I think a lot of people are interested in that because the idea is that it would maybe push or take the pressure off training so much at an early age. That is one of our survey questions that we're sending out to all of USA Gymnastics, so coaches, gymnasts, parents, what their beliefs are about that. I think the benefits to doing that would be that people would realize they don't have to train such young kids so much. I worry that they would still do it anyway because they believe that this has to be so for whatever reason that we're trying to understand. So I don't think it's as simple as just changing the age. But I think if we find that would drive change in behavior, then I would be supportive of it.
Thank you, Ellen.
Camila, se puder dar uma resumida e uma traduzida no que a doutora Casey disse, por favor.
Claro. Ela falou que, no geral, eles agora, na verdade, estão tentando, né, nesse formulário que eles têm aqui nos Estados Unidos, eles estão para técnicos quanto para os pais e outras pessoas envolvidas no treinamento desses atletas, né, tem essa pergunta, inclusive. Ela falou que acha interessante, sim, ela agradeceu pela pergunta, que achou uma pergunta bem interessante também. Ela acha interessante ter, sim, esse início um pouco mais tardio, talvez, né? Mas ela ainda acha que é muito cedo para falar sobre isso, porque não tem nenhum dado que mostre que isso vai mudar a questão das lesões, do aumento, né, das taxas de lesões, e eles precisam fazer mais estudos, e a maior preocupação dela, na verdade, é tipo assim, que mesmo que essa idade seja um pouco maior, né, se lá atrás eles vão também tomar esse cuidado de não ter esse nível de treinamento tão intenso, né, de volume de treinamento com os menores, né. Então, assim, ainda é uma coisa a ser muito estudada, mas que se os estudos mostrarem que isso realmente muda e que eles conseguem entender que eles não precisam começar tão cedo a fazer esses exercícios, né, tão intensos, que sim, que ela concorda e acha interessante mudar, sim, a faixa etária.
Mais alguma pergunta para a doutora Casey? Aqui, um minutinho. Espera aí que está um pouquinho longe. Só um minutinho.
We have more.
Oi, eu prometo que vai ser rápido. A minha dúvida com
relação...
Quando ela falou sobre o ciclo menstrual, a diferença entre, né, o gênero, que foi o foco da palestra, ela abordou sobre um estudo que falava da ovulação hormonal nas mulheres. E aí a minha pergunta ela acha que durante o treinamento, por conta dessa ondulação, das mulheres que não usam contraceptivo, seria interessante pensar no treinamento com foco nessa ondulação hormonal para prevenção da lesão ou não? O que ela tem como base no que ela leu e tudo mais?
É uma ótima pergunta. A gente discute bastante isso no laboratório também. Ellen, one of the questions that we always discuss, I think, in the lab or like research-wise, she was asking, like, based on the menstrual cycle phases that you show that, like, the ovulation have like more laxity, and also like between the athletes who takes oral contraceptives or not, do you think that if you change or like, make some changes during the training, paying attention on these like athletes who takes and don't take like OCPs, if you think that will make a difference, if we should think about like more about changing the training based on that?
Yeah, this is a really hot topic, which is great for somebody who studies this. You know, so many people are interested, even more than gymnastics, like when they're thinking about strength training, running, soccer for sure, are like kind of, there's so much attention to the menstrual cycle right now. And I would love to say that we know exactly how you should modify training based on the cycle, and every person is going to respond the same way, but that's probably not the case. And so I think it's a combination of, I do recommend athletes monitor their cycle, track it, so they know kind of where they are generally speaking. But unless you're checking urine or blood or saliva, maybe in some cases, to know what the hormones are, it's very hard to know where exactly they are in the cycle. So it's kind of a false sense of security to say you're on day 14, you must be ovulating, because in one person, there's a lot of variability from cycle to cycle. And between people, there's a lot of variability. So I don't think we're there yet to say you should do this type of training on this day. But I hope at some point when we can get easy, like saliva sample, track the cycle, look at wellness variables and recovery and those sorts of things, and all of that data could be input to adjust training. But right now, the people who are saying that can happen are putting marketing ahead of the science.
Thank you. Então, resumindo o que a Ellen falou, ela acha, sim, é um tópico realmente muito perguntado, discutido na pesquisa, né? Não só na pesquisa, mas no esporte, na medicina esportiva no geral, essa questão do uso de contraceptivos e como você pode fazer para modificar o treino dependendo do ciclo menstrual, da fase do ciclo menstrual que você esteja. Porém, ela acha que ainda está muito cedo para fazer esse tipo de mudança, porque você precisa ter dados mais robustos, né? Uma literatura um pouco mais robusta, e você também tem que ter como coletar, tipo, sangue e saliva, né, desses atletas ou desses pacientes para poder tentar pensar num futuro treinamento diferente, porque como existe uma variabilidade biológica não só do próprio indivíduo, mas também entre indivíduos, fica muito complicado você só pensar no contraceptivo, né, quem usa contraceptivo e quem não usa contraceptivo, e tentar pela tabelinha, né, pensar que lá no 14º dia você vai estar ovulando e aí você poder mudar esse treino, porque tem mulheres que ovulam no 14º, tem mulheres que ovulam no 18º, então fica uma coisa muito, como é que eu vou dizer, um guarda-chuva muito grande, né, para você pensar em como modificar o treino naquele período do ciclo menstrual. Então, é isso que ela falou, ela acha que precisa, sim, de ter teste de saliva e sangue para poder ter uma certeza, né, a mais do quanto de hormônio aquela pessoa tem naquele período, para se pensar em mudar o treino, e mais estudos. Porque hoje em dia os dados que tem não são tão robustos. Então, uma vez que a gente consiga ter isso, aí sim, ela acha que é fundamental você conseguir monitorar e mudar os treinos baseados, sim, nos ciclos, nas fases do ciclo.
Maravilha. Alguém tem? Encerramos. Eu gostaria de fazer uma pergunta, se possível, mas assim, eu vou fugir um pouco do tema, porque eu não sou nem da ginástica e nem da medicina, mas eu acho que o pessoal que está assistindo em casa pode querer saber, né, já que a gente está falando com a médica responsável aí pela equipe feminina da ginástica artística dos Estados Unidos. Para quem está assistindo em casa, eu vou perguntar primeiro as expectativas para os Jogos Olímpicos e também como é que ela enxerga o crescimento aí da ginástica artística brasileira em campeonatos internacionais. A gente tem aí, né, a nossa Rebeca Andrade, nossas meninas que estão cada vez mais brilhando em eventos internacionais. So, Dr. Casey, I would like to know what are your expectations for the Olympic Games, as you are the doctor of the United States team for the gymnastics, and also I would like to know how do you see the growth of the Brazilian gymnastics, as we have champions of competitions worldwide like Rebeca Andrade, who is our athlete. She's an Olympic champion, as you must know, and a world champion. Yes. We have Flávia Saraiva, Jade Barbosa, and so many that are doing so great in international competitions.
Yes, that's a great question. In terms of Team USA's performance, I mean, the good news is I have nothing to do with that. I just try to keep them healthy so they can do the best gymnastics, possible. And it's an honor to be the team behind the team and supporting them. So my hope for them is that they have a healthy and happy Olympic Games, and they're able to, be as physically prepared and ready to, do what their wonderful talents allow them to do. And I am very much looking forward to watching Brazil as well. As I said, I just think your athletes and your program are phenomenal. They are such a joy to watch. Their gymnastics is exquisite, and it's going to be a very tough competition.
Thank you so much. Essa eu posso traduzir, Camila, porque não é tão específica, né? Te dá um descanso. Vai lá, Júlia. Aí. Ela falou que, bom, graças a Deus, a parte da performance, né? Ela não tem muito a ver, né? Ela fica ali nos bastidores, ela só espera, a expectativa dela é que elas estejam saudáveis, felizes e dando o seu melhor, como elas sempre fazem. Tá com uma expectativa muito alta aí para os Jogos Olímpicos. E também falou aí, elogiou muito a nossa ginástica, né? O programa da ginástica artística brasileira, falou aí muito bem das nossas atletas e falou que como posso dizer, né, a competição vai ser acirrada, né, vai ser disputada, não vai ser fácil aí para a equipe dos Estados Unidos, porque claro, a ginástica artística brasileira está dando um show aí, como a gente sabe muito bem, aí com as nossas meninas e todas, claro, da seleção brasileira. Então vou passar a palavra mais uma vez aqui ao nosso doutor Cardone, para encerrar a palestra.
Obrigado, Júlia. Dr. Casey, thank you so much. You are invited to come to Brazil, to come to Rio de Janeiro, to come to Flamengo soon. Okay? Camila, muito obrigado mais uma vez.
Eu que
Espero aí até o fim do ano de novo fazer uma visitinha aí no HSS e conhecer a Antonella, né, que está vindo. Camila vai ser mãe daqui a pouquíssimo tempo, né? Então, muito obrigado mesmo a todos os presentes aqui. Eu acho que foi extremamente rico ouvir. Obrigado a vocês da Ginástica. Eu acho que foi super interessante aí as melhores perguntas. Então, abrilhantaram aqui tudo que a gente quer ouvir mesmo, enfim, para ajudar no nosso trabalho aí no dia a dia. Ok?
Cláudia, a gente que agradece o convite e é um prazer estar sempre aqui conversando com vocês. Com certeza eu vou falar para ela que dá.
Muito obrigada, doutora Camila.
I'm just saying,
Desculpa, sorry, you're going to translate, sorry. Go ahead.
No, don't worry, Julia. Just saying that the next time we're going, he's inviting us to go to Brazil, bring you to Brazil. I said to him, the next time I'm going, you're coming with me.
Love it. Great idea.
Okay,
Thank you so much for the opportunity. This was really wonderful.
Thank you so much, Dr. Casey. It was an amazing lecture. Thank you so much. Muito obrigada, doutora Camila, e muito obrigada também, doutor Cardone, por trazer essa palestra aqui para a Gávea e para a Flá TV, todo mundo que está assistindo, né? Então, eu vou ficando por aqui, espero que vocês tenham gostado, e até a próxima. Flá TV é mais Flamengo para você.